So, diabetes and pregnancy. Okay, it's a relatively recent problem. Okay, it's very important to separate pre-existing, so pre-gestational diabetes, either type 1 or type 2, and gestational diabetes, so hyperglycemia during pregnancy. The definition of gestational diabetes mellitus changed over time. Before, it was considered any kind of hyperglycemia that solves after delivery. Today, gestational diabetes is any kind of hyperglycemia diagnosed for the first time during pregnancy. And as we now know that approximately 20% of women with gestational diabetes will have some kind of glucose intolerance after delivery. So 20% of women with gestational diabetes, that is any kind of hyperglycemia diagnosed for the first time during pregnancy, will have some kind of glucose intolerance after delivery. Pregestational diabetes is either type 1 or type 2, but also any other kind of diabetes. So women who had pancreatic surgery or genetic forms of diabetes. It may also happen that type 1 diabetes or type 2 diabetes were already present before, but they are diagnosed only during pregnancy because she wasn't aware of that. So pregnancy was actually just the occasion to find it out, as she had blood tests for pregnancy. Gestational diabetes almost always goes away after delivery, even if it may remain the glucose intolerance. So, gestational diabetes go away, but we can have glucose intolerance, which is defined as a threshold. I don't remember now. It's between. It's not as high as glucose as diabetes, but still is not perfect control. And so in case of diagnosed or undiagnosed pregestational diabetes, you have hyperglycemia at the time of conception, while in case of gestational diabetes mellitus, hyperglycemia is present only after conception, and the problems are related to the growth of fetus. There are two separate sets of problems, two different ways of treatment and follow-up. So, the time of conception, while in case of gestational diabetes, hyperglycemia is present only after conception, and the problems are related to the growth of fetus. Okay, so the most common form of diabetes is the gestational one. About 20% of pregnant women will develop it. Prevalence of gestational diabetes in different populations is extremely variable, from 3-4% to 20%, because it depends on screening policies in different countries. Native Americans have high rate of type 2 diabetes mellitus. They also have high incidence of gestational diabetes. So as we see here, we have type 2, type 1 diabetes, can be pregestational, it can be diagnosed during pregnancy, it can be gestational, so it just happens during pregnancy. So we have like two cases. One is already present but can be diagnosed only during pregnancy, and the other is the one that the proper gestational diabetes that happens during pregnancy. Pregestational diabetes prevalence, type 1 is 2.6 per thousand deliveries. Type 2 is 1.8 per thousand deliveries. Then we can have other forms of diabetes, and we can also have impaired glucose tolerance or impaired fasting glucose. This study is of about 10 years ago. Okay, so now women with type 2 diabetes mellitus account for 30-40% of pregestational cases, and consider also the increase in maternal age. Pregnant women, in a pregnant woman, it's always imperative to consider both maternal and fetal well-being. For type 1 diabetes mellitus, it's important to consider that in the past these women didn't conceive, as diabetes wasn't well controlled. The only way to carry out a pregnancy is to keep the diabetes is to keep their blood sugar levels as close to normal as possible, and this was reached in different ways over time. Okay, then there is some history. So we can have a risk of major gestational fetal malformations in case of pregestational diabetes. The risk depends on HAB, glycated hemoglobin. The more the exposure to sugars at conception, the higher the risk of malformations. The best option we have is to normalize the blood sugar before pregnancy, so a good control of diabetes, avoiding the major risk of normalization of blood sugars, which is hypoglycemia. Pregnancy gives women a very high motivation obviously to keep blood sugar under control. Women with pregestational diabetes do have excess in neonatal death, in major malformations, in macrosomia, premature delivery, and excess in C-section, due to the macrosomia or because of emergency complications, like high preeclampsia rate. The risk of death in the fetus is proportional to the level of glycated hemoglobin at the time of conception. And okay, so it's very important to convince women to come to diabetes office before they get pregnant, because after is we start the risk, we have the risk of malformations, fetus malformations. So, why hyperglycemia affects the growth of the child? Because glucose crosses the placenta, being the major source of energy for the fetus, but insulin does not, with the exception of the IgG-bound insulin, which however is not relevant. Therefore, the insulin secretion of the fetus will be triggered and the baby will be exposed to high levels of insulin. Insulin is an anabolic hormone, so this results in macrosomic baby. And macrosomia triggers a lot of obstetrical problems and problems for the baby as hypoglycemia, ICU need, etc. If you are exposed to the hyperglycemia during early pregnancy, you can have organ malformations or abortion, even if the woman is not diabetic. There is some kind of hyperglycemia imprinting remaining in the gene in the child, increasing the child's risk to become obese and to or develop diabetes later in life. So there is a risk that the infant carries on. If you are exposed to hyperglycemia during late pregnancy, you have increased risk of macrosomia, so increase of premature delivery, as said, C-section, polyhydramnios, and increased risk of metabolic complications both in the mother and the child, like diabetic ketoacidosis or hypoglycemia. Okay, there are physiological changes of the carbohydrate metabolism in pregnancy. We have mild fasting hypoglycemia, we have postprandial hyperglycemia, which increased plasma volume, increased fetal glucose utilization, increased insulin clearance, and progressive increase of insulin resistance. So HPL, prolactin, and cortisol increase. So we can have mild fasting hypoglycemia, postprandial hyperglycemia, and progressive increase of insulin resistance. And these are the physiological changes of the carbohydrate metabolism in pregnancy. If you meet a diabetic woman, at least you have to inform her about the 4 rules of diabetes in pregnancy. If your glycated hemoglobin is not less than 7, don't get pregnant. First. Second, let us know all your complications if you have diabetes, hypertension, renal impairment, retinopathy. If you have to do laser treatment, it's better to do that before getting pregnant, as in the first trimester it's better to avoid anti-inflammatory drugs. And cardiovascular problems. 3. Let us know about all your medications if you take some, except the insulin. Other medications in diabetes, mainly T2, type 2 diabetes, are contraindicated in pregnancy. 4. If all these rules are not met, use contraception. The GP have to be aware of that, not only endocrinologists, as for example, general practitioners are the ones treating the type 2 diabetes patients, and these women have a lot of complications. So, counseling before pregnancy for diabetic women has the aim of optimization of metabolic control, glycated hemoglobin and targets, evaluation of diabetes complications and comorbidities, rheumatoid arthritis, rheumatological diseases, hypertension, chronic acidosis. Review medication. Remember to give them folic acid. And folic acid. Discuss risks and how to potentially reduce them. Discuss contraception if they need some time to reach these goals. Okay. Gestational diabetes. Now we'll talk about gestational diabetes. It's more common than the previous one, so than pre-gestational diabetes, which is the diabetes that is present, type 2 diabetes or type 1. So gestational diabetes prevalence is variable depending on how detailed you are in detecting it, which depends on the underlying risk in your population. There are maternal and fetal risks related to gestational diabetes, and they are not that different from the risks of pre-gestational diabetes, except for the fact that gestational diabetes mellitus doesn't increase the risk of abortion or malformations because the fetus is not exposed to hyperglycemia in early pregnancy. So the main risks are related to fetal growth, giving problems at the time of delivery. Well, gestational diabetes is considered also a marker for increased risk of type 1 diabetes mellitus development in the mother. Family history of diabetes is very relevant, so it's important to ask if parents or grandparents have diabetes as well. So, it's not always easy because it depends also on the population of origin. In some countries there are no screening programs for diabetes, or pregnant women come from countries where people get pregnant very early, so maybe our parents are too young to have developed type 2 diabetes. There is also a recurrence of gestational diabetes in second pregnancies unless you change your habits and diet, lose weight, exercise, healthier lifestyle with respect to the previous pregnancy. What we know from experience of populations with high incidence of gestational diabetes, children have increased risk of developing obesity, impaired glucose tolerance, type 2 diabetes mellitus later in life, and this is not only dependent on genetic factors. So there are risk factors also for children. considering two siblings, one born from a gestational diabetes pregnancy, the other from a physiological one. The one from gestational diabetes develops more often earlier type 2 diabetes mellitus, even if it's the youngest. Therefore, it's important to investigate and screen for gestational diabetes during pregnancy. Why do you have hyperglycemia? You either have a decrease of insulin sensitivity or a change in insulin secretion. So these two are the main reasons for this gestational diabetes. A decrease of insulin sensitivity may continue postpartum. A change in insulin secretion, so you have a decrease of first phase at IV glucose tolerance test, delayed secretion at oral glucose tolerance test, decrease insulin secretion at a mixed meal, hypersecretion of proinsulin in some women. Okay, so we can have the oral glucose tolerance test is the one mainly used for gestational diabetes. It's done at the 24-28 weeks after a 75 grams of glucose. If you have a fasting glucose more than 126 milligrams per deciliter or a random glucose more than 200 milligrams per deciliter or glycated hemoglobin over 6.5%, we have a diagnosis of overdiabetes in pregnancy. The risk factors for gestational diabetes are family history diabetes, such as in first-degree relatives, ethnicity, South Asian, Middle East, Afro-Caribbean, age more or equal to 33 years, pre-pregnancy obesity or overweight, so BMI more than 25, gestational diabetes in previous pregnancies, previous macrosomic baby, adverse obstetric history, so miscarriages, polyhydramnios, high risk of gestational diabetes if obesity is more than with a BMI of more than 30, gestational diabetes in previous pregnancy, or fasting glucose of 100-125. Okay, so the idea is to screen only women that are at risk for these factors, for gestational diabetes. And so family history, ethnicity, South Asian, Middle East, age more than 35, pre-pregnancy, obesity or overweight, previous macrosomic baby, adverse obstetric history, and gestational diabetes in previous pregnancies. These are the criteria. As said, exposing the fetus to hyperglycemia in uterus induces changes in the metabolism of the child, leading to obesity in childhood and later in life, and to type 2 diabetes mellitus. The more gestational diabetes mellitus, the higher the prevalence of type 2 diabetes and obesity in young population. And in the case these are women, they will likely expose their future fetus to hyperglycemia, so a vicious cycle is established. So in pregnancy, target values are lower than targets outside of pregnancy, the glucose targets, and glycated hemoglobin should be 6 or lower, while outside pregnancy a value of 7.5 is considered a good target. Okay. And treatment of gestational diabetes. We don't use oral medications as none of them can be used in pregnancy. What is universally accepted is a diet with 100, 1600, 1800 calories per day, 50% carbohydrates divided in 3 meals and 3 snacks. Anyway, in 85% of cases the diet will be enough to control so in 85% of cases the diet will be enough to control blood sugar levels, and we don't have to worry further except for motivating them to measure their blood sugars. For the women who can't reach the target values, the only medication approved in pregnancy is insulin. Depending on whether the woman has insulin resistance or insulin deficiency, we would use either a long-acting or a rapid-acting insulin. Women with insulin resistance have high blood sugar in the morning, so we'll give a shot of long-acting insulin in the evening, and usually they will have good postprandial values. Women with deficit in insulin secretion will have problems in the postprandial values, so you give them rapid-acting preprandial insulin. So you have to tailor the therapy to their needs, and as you should always do in diabetes. Insulin is not welcome by women, but usually is transiently used for a couple of months, so it's accepted. There are some oral medications under evaluation in pregnancy: gliclazide and metformin. Metformin is safe for the fetus, and it's also used in polycystic ovarian syndrome, and they actually conceive under treatment of metformin. The polycystic ovarian syndrome pathogenetic mechanism is insulin resistance, and often they can't be pregnant, but after a few months of metformin, they can actually conceive. Well, the main reasons for concerning for oral agents in gestational diabetes are convenience and costs. Treating and monitoring gestational diabetes requires a lot of costs, but meta-analysis shows clearly improvement and prevention of the possible complication if sugar levels are kept under control. The time is critical. A diagnosis around the 24-28 week gives you the time to control and adjust the levels. Okay.